right, so I'm going to talk about the aging revolution, and I have a few slides to talk. If you want to interrupt me at any point, please do. But I do want to have an open discussion, and I'll tell a little bit about the process as we go along. So the aging revolution, next slide. So I'm going to talk about the book process, how I came to be one of the co-authors, why there is a need for an aging revolution. I'm going to talk about age-friendly health systems, the importance of family caregivers, and goal concordant care, person-centered care planning, which is fundamentally what we need. If you go back a slide, I just want to say that I'm an internist, and ACP has been my organizational home. I found it beneficial for me because there were a lot of events that were local that I could take part in as I was raising my family, and I found that easier than some of the other organizations that you have the annual meetings, and those were harder with the family and traveling. I'm a geriatrician and a palliative medicine physician. And then about 2 years ago, I completed a health and aging policy fellowship, which had a parent home at Columbia University, but took part in DC. And the Aging Revolution, the book, is actually a combination of all of these backgrounds, because there's in primary care, we talk about, there's geriatrics, palliative medicine, and then advocacy is a big part of the book. So next slide. These are the chapters of the book. The Man Who Saw Old and New is all about Robert Butler. And if you've never heard that name, you should try to read whatever you can on him. He was the founding director of the National Institutes of Aging, and he was my chair when I did my fellowship at Mount Sinai. And Mount Sinai now is home to the Department of Geriatrics and Palliative Medicine. And then the other chapters, we talk about delivering care at home, geriatric syndromes, age-friendly health systems. It tells the history of the rise of palliative medicine, the invisible workforce or family caregivers. And then we go into this new modern age of value-based care. It's the chapter's called Value-Based Wildfire. Talk about the medical industrial complex and how older adults play a role in it. And chapter 9 is the undisputed workhorses of American medicine. It's all about primary care and how we really have to reinvent it. And then number 10, the 10th chapter is the power of small things. And that's really identifying what really matters to older adults. Next slide. So there is a need for a revolution, and I'm going to talk about the healthcare and population trends that we're seeing. Next slide. This is a dynamic slide. It shows the percent of the population by age from 1950, and we're going through to 2050. And in 1950, World War II had ended, and young families were having babies. And now, near 2000, we have those baby boomers entering the over 65 population. And the fastest growing population now is over 80, as you see. So what used to be a younger age population, we are now a more populated older adult population. You can get a sense of that. Northwell Health, our strategic planning division, was able to do a heat map of older adults. The darker the red, the higher the percentage. And we put our hospitals and how they land. And you'll see Eastern Long Island is very dark percent population of older adults. And where I work is kind of towards the Nassau-Queens border. These two, I don't know if you can see my cursor, but 2 hospitals there is, you know, where it's red everywhere is basically what I'm trying to say. Next slide. And what's important when we talk about the older adult population, I think this slide and how healthcare needs to evolve. We all live in this world where there's disease-centric care. And if you look at Medicare fee-for-service beneficiaries, heart failure, only 1% of individuals with heart failure just have heart failure, but 66%, the blue, have 5+ other conditions. And our health systems are evolving to create this disease-centric world, right? Heart hospitals, cancer institutes. But the challenge moving forward is to be caring for individuals with multiple medical problems. So just like this, heart failure, we shouldn't just focus on the heart. We've got to focus on the 5 other conditions. Next slide. But this older adult population, which will be all of us at some point, is varied, right? You could be Rita Moreno in her 90s who's making movies and dancing and singing and highly independent or not. This population is heterogeneous, it's complex, there's sensory challenges at times, and psychosocially variable. Next slide. This is another way to look at this population and how we age chronologically on the bottom graph and functionally. We're born, we're independent, we stay in this independent phase, ideally, and then we enter frailty and disability for a shorter period of our life. That's ideal. But there are things we do in society or society does to us that accelerates aging. And sometimes we are living in a frailty and disability phase too long. We want to try to prevent that. And we don't want to contribute to the accelerated aging. And I think hospitalization itself can sometimes cause harm, and we have to be careful. We want people live independently for as long as possible. And that concept of being frail and disabled, a disability phase, a shorter period of time is actually called compression of morbidity. Next slide. And this is another way to look at it. We're healthy to the left. We have acute illness, reversible, it's treated, you're fine. Then you start accumulating some chronic conditions, but they're manageable and they're early. But then later on in life, these chronic illnesses become more serious. They're limiting your activities of daily living. You're functionally impaired. And then that's when you have multiple problems, it's impairing your function. That's considered advanced illness. Maybe you treat one thing, it hurts another. How do you manage this phase? How do you manage multiple problems that's causing functional loss? And how do you start identifying when somebody's hospice eligible? This is the population. Next slide. And then there's ageism with as we get older. This is Robert Butler. And the first chapter of the book is all about him and his book, Why Survive Being Old in America. And he won a Pulitzer Prize for this book and became the founding director of the National Institutes of Aging. He coined the word ageism. And we see it in society. We do it inadvertently in hospitals in our everyday. We make assumptions about people. We don't assess their baseline or ask what they're capable of. We maybe talk to their family member before talking to them because we think they don't hear us, but we're doing this all the time. And we should be aware and try to minimize our biases, but and teach others about this term ageism. Next slide. The other thing that's happening in society, and the book we write about in actually the second chapter, is care in the home, independence at home, hospital at home, house calls, or home care medicine. People are living in home. They're being sent home earlier from the hospital, so they're sicker. They're getting infusions, they're getting wound care, they're doing injections, and we're expecting families to do this. That's really our way of providing care in the home, is through family support. And we're asking them to do medical and nursing tasks that they often aren't educated on. Next slide. And what we don't do well is identifying individuals' care needs. This is a study of 12 hospitals and their general medicine patients who were readmitted within 30 days. And if you press it once, please, you'll see that on discharge, and they evaluated them on readmission, and they did not have difficulty understanding their discharge instructions. Only 6% had difficulty. And if you press it again, but 56% had self-care needs. So we're not assessing in patients' abilities to follow instructions or the care plans we've given, and we're not asking if they have care support. And this is often contributing to readmissions. Next slide. And then another thing about our society, and specifically in New York State is the lowest in hospice utilization. We are number 50 out of 50 states. And actually it's improved because the year before we were below Puerto Rico, but we moved up a slot. But we have room to go. We're able to get families to do infusions, injections, and so forth. But for some reason, families aren't choosing, we're not recommending, but we are the lowest in hospice utilization. Next slide. Another chapter that we talk about is Medicare. Medicare currently is, we're in a time of uncertainty with Medicare, Medicare Advantage, and Medicaid. It's, even for the average person, it's complex to understand this benefit, and it's changing, but we have a responsibility to be on the watch for what's happening. We have a responsibility to protect and have some stewardship about utilization of our healthcare. Medicare is not only a payment system, it's also part of our quality. Star ratings, for example, of our hospitals is all through Medicare and Medicare population. And it's also part of our education. A lot of funding, our ACGME funding, is through Medicare. So I encourage you to read the book. We spend about 2-3 chapters on Medicare, Medicare Advantage, and the medical industrial complex. In my health and aging policy fellowship, I was embedded into CMS, Centers for Medicare and Medicaid Services. And there are some truly incredibly bright, professional people, and we need to be careful and protect Medicare. Next slide. When we talk about older adults, it's really about living with and living longer, managing multiple medical problems, so multi-complexity. Next slide. With age, increases your prevalence of dementia. And here you can just see that over 70, but by the time you're 80 to 90, about 50% of that age group have dementia. Next slide. And we've made progress with other diseases. There's lower mortality rates because of cancers, heart disease, stroke, HIV, but more people are dying because of complications of dementia. Next slide. And we don't really necessarily see the dementia. People are hospitalized because of other illnesses that we're managing and treating, but the dementia is complicating the hospitalization, for example. The other thing that we're dealing with is that treatments have advanced technologically. Heart failure, if you use that as an example, all the different heart failure treatments are, it gets very complex. Diabetes gets very complex. Stroke management, cancer treatments, organ transplants. There are way more treatment options today than there were 2 decades ago. Next slide. And we're also seeing an increase in what we call geriatric syndromes, which is falls, delirium, polypharmacy, that contributes to all of that. Next slide. So what we need, because of these healthcare trends and multi-complexity and all the treatment options, we need really person-centered care planning. And that is the innovation. It is important, but how do we do that? If you have multiple problems, you have, and doctors or clinicians make the care plan, but they're often making a care plan for an organ or for a problem, and the family members and the patient are getting multiple care plans, and it's overwhelming. So how do you make person-centered care plans so that they're not having to follow 20 different care plans and synthesize it? Next slide. The innovation here is age-friendly health system. Next slide. It's a 4M framework, and I'm not sure if everybody's heard of it, but at Northwell, we're really leaning into this age-friendly health system initiative. It is it's evidence-based framework that has tools for each of the 4 M's: what matters, medication, mentation, mobility, evidence-based tools. And if you teach how to use the tool for each of the M's, you can show and impact quality. Go through, next slide. And the 4 M's, it's a framework. It addresses older adults' core health issues. It builds on strong evidence base, and it's synergistic relationships with an opportunity to simplify and reduce burden on the care team. We have found that if you use this framework, it helps the clinician clarify and prioritize a care plan, which helps decrease their burden. Next slide. There's also a business case to age-friendly, fewer hospital readmissions because it's evidence-based. If you do the 4 M's, even higher quality metrics, but it's fewer hospital readmissions, better outcomes, more satisfied patients and families, and lower overall costs. Next slide. So for what matters most to an individual? Is it to be pain-free and comfortable, or is it to survive the issue you're dealing with? If you discuss what is the most important thing, what matters most to you, it helps clarify this decisions, and it's shown to lead to unwanted ICU care and less days in the hospital. Medications, focusing on avoiding harmful medications, leads to adverse drug events. Mentation, screening for delirium, prevents more significant delirium and poor outcomes. And mobility, by showing focusing on independence and mobility, it lowers in fall rates and pressure sores and DVTs. Next slide. So the book, we talk about age-friendly, the framework, how it came to be. And Northwell, we've been very active on it, and we've been nationally recognized, and that's a whole nother discussion. But Michael Dowling, who was the impetus for this book, has really leaned in to age-friendly health initiatives. Next slide. Just going to talk briefly about family caregivers. Next slide. And you can't be truly age-friendly unless you address the needs of the caregiver. And this is from the John A. Hartford Foundation, Ronnie Snyder. And the John A. Hartford Foundation is a funder of the age-friendly health system initiative. Next slide. So this is a study that showed that 2/3 of hospitalizations were preventable in congestive heart failure because of poor compliance with medical therapy and failure to seek help with escalating symptoms. So what they say is, to prevent these readmissions, involve the caregiver in the care. Look for a pathologic caregiver. Assess impact of interventions on caregivers. And if you involve the caregiver earlier, you can prevent the readmission. Next slide. There's been a lot of talk about caregiver burden, but if you involve the caregiver, you empower them and you help the health outcomes. If you go back one. Yeah, and these are just some other articles about if you address the caregiver earlier, the outcomes are better. Next slide. And caregivers they want education. They want support, they want education, and they want linkage to resources. Next slide. We did this one earlier, we can keep going. At Northwell, we have caregiver centers at some of our hospitals where we are trying to link caregivers to social workers and resources, education, and support. Next slide. And then in primary care, the book talks about the reinvention or reinventing primary care, the workhorses for the health system. Our society is better if you have good, robust primary care, but we have to reinvent it because right now the model of seeing patients with multiple medical problems, who have functional impairment, who you have to discuss what matters most to them, and you may need a social worker to help you. You have to support it. So Christine Ritchie and Bruce Leff have this home-based care reimagined, where it starts with a primary care hub, physician, social worker, but you have the ability to link patients and families to resources in the community, pharmacy, how to get the durable medical equipment, hold goals of care conversations, link them to home care, house calls eventually, hospice. Can you have family meetings in your office? Is there tele-EMS? Really link the patient and family. So there's a hub, but you link them to the community-based resources and eventually move them to either house calls or hospice. Next slide. So I just want to tell a quick story about the book and how it came to be and my involvement with it. And then I'm happy to take questions about the experience, and maybe I'll put Izzy Newman on the spot because she helped edit a chapter. But about 2 years ago, Michael Dowling, who is the CEO of Northwell Health, called me, and it's not every day the CEO of the health system calls you. So he said, I'd like you to present on all the services in the space of aging. And you have an hour and you can bring whoever you want. So I had to think what that meant, aging. And we had cases. There were about 8 of us. And we had a case and we talked about what that case led to and why that's aging. And it ended up really being the outline for the book without realizing it, because we talked about polypharmacy. We talked about caregivers. We talked about home care, house calls, primary care. We talked about payment systems that were not in alignment with the care we're providing. And we talked about palliative medicine and geriatric medicine. And then Charles Carney, after that meeting, which started out as an hour, became 2 hours. After that meeting, Charles Carney said, well, who should we interview for this? Who should we interview for that? So over a 2-year period, we interviewed about, over 100 people. Some parts we used in the book, other parts we didn't. And it was just a phenomenal experience for me. I learned so much about how a book becomes a book, right? From the start to what actually was the final product. And now I'm learning, just the whole circle of getting the book out there and talking about it. While this book talks about the history of geriatric health care with Robert Butler, it's more than just the geriatric healthcare. It really is a book about healthcare, health systems, and how we need to advocate for the change. We're working in a healthcare system that was built for acute care and not for this multiple chronic conditions. And I think this task force of geriatrics and palliative medicine at NYACP should be really advocating. So my ask to you all is to join the revolution and share the book. It's something you can read chapter at a time, and it's on Audible as well. And there's a link here for the Amazon if you're interested. I'm happy to take questions. Izzy, I'm putting you on the spot. Do you want to say anything?
Hi, sure. Thanks for calling on me, and thanks for I'm glad we're giving this talk. It was a great opportunity to work with you on this book, and I'm really excited, about the future of geriatrics. I think it's a really exciting time to be a part of this, aging revolution, as you put it. The need is clearly really immense, and there's so many passionate individuals, working behind the scenes in advocacy and, directly with patients, teaching about how important, the care of these older adults is and is going to be moving forward. The population's growing and aging, like you pointed out. So I'm excited about the future of this field. And grateful for all the, the mentorship I've had so far. I'm open to any questions from anyone, if you're thinking about training in geriatrics or palliative care. Thanks.
Hi, Andre.
Dr. Carney, thanks for the presentation. I had a question on one of the slides. It's very interesting that New York, despite, in my head, being a resourceful state, we're just barely beating Puerto Rico, it sounds like. And
oh yeah, it's amazing, right?
It's doing better than us, and I wonder, why that might be the case.
Yeah, Isaiah, I don't know if you can go back to that slide.
I was trying to think in my own experience, in my training and residency, why that might be the case. And the only thing that comes to mind for me is training in New York City. There's a very high immigrant population. And I think abroad, maybe hospice isn't particularly well received, like among other cultures. And maybe there's an opportunity there where we can better communicate or better, I don't want to say advertise hospice, but kind of explain what it is. Maybe there's a barrier there that we can.
Yeah, if you look at all the other states, they're in the 40s or higher until you get to the 1, 2, 3, 4, 5, 6, the last 7. Then they're in the and this is the percent of Medicare who beneficiaries who use hospice by state. So we are like very, very, New York State is extremely low. And not to get controversial here, but New York State is like having this Medical Aid in Dying Act, which I think, you can say what you want for it, but we're not even getting people like taking a hospice approach, much less go straight to medical aid in dying. So from an advocacy point of view, that's something I think New York State we should improve upon is utilization of hospice.
Yeah.
But I don't know, Texas has immigrants, I'm like, and
yeah.
Where's California on here? Is California low? Let me see. Well, they're at 43.98%. We're at 26%.
I think half the battle also is maybe, I think, doing these kinds of presentations and highlighting the fact that, we could do better as physicians in trying to communicate and really advocate for this. Maybe that's half the battle.
That's half the battle. Yeah. Did the number break out regions in New York State? I don't have that information. That's a good question, Jenny. Is it rural or not? But I don't know. Good question.
Dr. Carney, I was interested in sort of your last slides about primary care.
Yeah.
And how primary care could be reimagined to better encompass a more age-friendly approach with these hubs that eventually can kind of go out into the community to provide resources. I do feel that we're on the cusp of a change where we're trying to rethink primary care, but we really aren't quite there yet. And I think one of the values of these types of discussions is getting people from different parts of the state and different health networks to kind of compare ideas. I'm curious sort of what your experience has been at Northwell in terms of trying to initiate some of these ideas.
Yeah, well, So Andre and Isabella train in our geriatrics and palliative faculty practice, where we have two social workers, a pharmacist team, and we're the #1 referral to hospice, as one example. We take care of our patients until then they get more homebound, then maybe we'll do a home visit to evaluate their needs. Maybe we can refer them to house calls. If not, we try to refer them to hospice from the community, not from, often many doctors will refer to the hospital to then go to hospice. But we see a lot of patients with dementia and multiple other problems. I personally think we need these hubs, and we're trying at Northwell to do one of these hubs in each of our regions. So we put a new one in the Eastern region, and then we have one in Manhattan, but they're in their infancy. But the need is so greater than what we have. I've heard some of my colleagues elsewhere out of Northwell, some of them are looking at primary care with shift-like work, because many younger physicians want shift that's attractive to them. So, can we do that? Can we create teams? I don't know, but I just know that families, patients it gets very difficult to see all the specialists all the time, and there comes a stage of life where it's harder, and that primary care needs to take on more.
I'm just curious, how does the hub actually work? So like in our practice, so mine's a pure geriatric practice. We do have some of the home visits. We try to do the comprehensive care. I follow people in a life care community,
Yep.
we refer to hospice, running into the staffing at hospice and getting some of my patients in.
Yeah.
So, as our primary care practice, we're doing our best, but obviously getting overwhelmed. Our social worker had to go out, so it's just but a lot of these practices won't be able to have a social worker, a pharmacist, especially in private practice.
Oh, yeah, no, this has to be subsidized by
Yeah.
either, and we're very fortunate as our health system subsidizes our practice.
Yeah.
But I would
And
say,
we have that support too, which is good. But what is that hub? Is that the hub is the practice and then you have it all within there, or you said you had one and a few?
that hub, well, this hub, which we are trying to do with our Jerry Pal office, but Christine Ritchie and Bruce Leff write about it in a Health Affairs article, and they have written on other articles about primary care, home-based ecosystem, where they connect more. Maybe they start as primary care, but they're connecting with home-based services, and that's the future. And then, do you use PACE models of care? Do you there's so many, a GRACE model of care is another model of care that's out there that you have access to help, but you're still the boss or the lead here, and utilizing whatever are the different models of care and supports. As a healthcare system in society, it's often that our primary care patients start getting lost to us because they're not able to mobilize or they're dependent. So they are and we have the data, they are starting to use the emergency department as their primary care. That's expensive care that Medicare or private insurance is spending. So if we can keep them out of the emergency department, keep them home longer, and create this home-based ecosystem within a primary care, we will save money or provide, and they don't want to go to the hospital, but they're less mobile. So that's one aspect of trying to move in that direction. But it takes metrics. It takes showing that you're not utilizing emergency department. It's hard for us to show that with our electronic health record. So we capture our referrals to hospice from the community. That's our return of investment. And our practice is the #1 referrer from the community to hospice, more than our cancer center. And, you know, that speaks to our leadership. And it's not easy for families to do hospice, let me tell you. So,
But oftentimes you'll find out how relieved they are when you bring up those options, you know. So it's oftentimes it's the understanding, you know, because
yes,
again, we get focused on our multiple comorbidities that we deal with, and then we don't just take that time of like, why the four M's matter. What matters to you? And you
yeah.
can oftentimes get them to transition to hospice when they know how that will support what their needs are.
And a
we're
lot of
not
people
giving up
don't
on them.
understand what hospice is, Andre, to your point, that it's services to deliver to you, to keep you out of the hospital. I'm going to use this word, it's going to sound scary,
Yeah.
but these services are, and then I say hospice, and then they'll be like, oh, okay. yeah,
Absolutely. And that I won't abandon them. That
right.
I'm still part of that process, that they still have to talk to me, you know, so, and that again, usually reassures them
Yes,
a lot. So.
yes, the key word, abandonment, non-abandonment. I think there's a question here. I can't read the whole thing. Thank you for the information. Can you please speak to the business finances of, hold on. Business of complex care hub implemented, especially given current discussions regarding significant Medicare cuts. Well, what I've heard about the cuts are there's $880 billion of cuts of Medicare and Medicaid. It's not been identified what will be cut or how it'll be cut. We imagine a lot will be Medicaid. I don't know what's going to be cut in Medicare yet. So we have to watch, we have to communicate, we have to share if you've read something, if you're in group chats, share what you've read, where you think, advocate for your legislators. And I'll just say that we're spending this money in healthcare. Individuals they're utilizing the emergency department. So if we don't reach them in other ways, they're going to be spending money or healthcare dollars in some way. And we do have models of care, like, I don't know if you know about the GRACE model, it's mentioned in our book too, but nurse practitioner, social worker that go to the home and then report back to the primary care doc. It's shown to save money. It's shown to align with what patients want. It's shown to prevent emergency department visits. So linking your primary care office to these other models of care, identifying who has it, where they are, is needed and will save money.
Yeah, I think that's the real point is that you've really laid out, you know, kind of how things are changing, how there's more of the population who's older, how they have increased care needs, and how they get left behind. And I think pointing out that this is significant costs associated with that, and if our interest is that we want to if the goal is to save money, really, then you know, doing this makes a lot of sense.
I don't know if it's to save, I mean, save money or to be stewards of Medicare and, you know, use it correctly, I would say. I don't know, or not waste money. Maybe that's a better way for me to say it.
I was struck in your presentation earlier when you were discussing hospitalizations and how it wasn't really a lack of understanding of the discharge instructions, but a lack of attention to the care needs or the ability to put forth the plan without much thought. And I find that to be very, very true. And perhaps discouragingly, there's been a focus in Rochester as well about age friendly health system, but I feel that there's also a competing pressure of reducing hospital admission length of stay and discharging people quickly. And I feel then sometimes with that there's a bit of a conflict where really that attention to the ability to understand functional ability is lost. So I thought that was a really interesting point that you had.
Thank you. It you know, I see it, and there's a theme of CHF here. I don't mean to have that, but you know, I've had cardiologists say, well, I told them to weigh themselves every day, this and that. And I'm like, my patient can't stand on the scale. You know, just some kind of basic information. What do you mean they can't stand on the scale?
I love the idea of the caregiver hubs in the hospital to provide a centralized place for resources. I think that's just a really wonderful, wonderful idea.
We've been very proud of it. It's a volunteer, it's a social worker manned center, and they have volunteers that go through the hospital. And if there's a family or family caregiver that nurse managers have identified, they will have the volunteer meet with them and then connect them to the social worker in the caregiver center. Most patients don't get access to a social worker to say that they have needs unless they're hospitalized. Most social workers in hospitals are for discharge planning. And sometimes if you have a loved one who's had a new stroke and they can't, it's a new state for them, they're overwhelmed, they don't know what they need. So we have found that these caregiver centers have been helpful in that way. We're trying to show their impact, like how are they helping patients and outcomes. 9 of our 15 hospitals in the metropolitan area have these identified caregiver centers in the lobby, so that you walk in, you see, oh my goodness, it sends a message that we're here not only for the patient, we're here for the family. And so we're very, very proud of it. Our other hospitals do have caregiver programs, not necessarily identified locations, but we know from literature, family caregivers need support, they need education, and they need resources, and that's what those centers aim to do. Did I miss any other questions on the chat? Okay. Well, if there's nothing else, thank you. And please share the book. If you have read the book, please put a review in Amazon or wherever you got your book, because I'd love for other people to read. I'm very proud of it. And I really thank you very much for letting me do this.
Thank you. I'm actually going to read a little bit more on the Medicare Advantage. I even just recently had one of my patients I'm used to, you could lose your days. I mean, you have to, after 100 days in rehab, and if you don't stay out for 60 days, Medicare doesn't pay anymore. I did not realize that was also for acute care in the hospital.
Huh.
I was just reading up on that. I was like, what are you talking about? You could go to the hospital and they go, I need to be out for 60 days. I only have 20 days left. After that, I'm going to have to pay. And I was looking into it and I did not. And I deal with a geriatric patient, Medicare population all the time. I did not realize that. I'm still looking into that because it floors me.
So I do want to comment on Medicare Advantage. So there's Medicare fee-for-service that everybody gets, and it tends to be more expensive for individuals. Then there's a Medicare Advantage, which is a private insurance company will make a Medicare product, which tends to be cheaper monthly cost. And easier because there are brokers and you get drug costs in there. So Humana, United Health, they have a Medicare Advantage product. Medicare did this because they wanted to see if private insurance could lower costs of Medicare. And there's going to be more now. 50% of all Medicare beneficiaries have Medicare Advantage, not Medicare fee-for-service. How it works is you get a narrow network of what physicians you can use. You have limitations on costs. You have limitations on medicines. And it all is the fine print on who you partnered, what Medicare Advantage product you have, whether it's Humana, United Healthcare, or some other company. Now, if the insurance company saves money, they make profit, that profit goes to shareholders. Doesn't go to Medicare, but maybe you're spending less to Medicare. So it's very, very complex. They expect 70% of Medicare beneficiaries to have Medicare Advantage. Value-based contracts are working with these private insurance products of Medicare Advantage. So we're in a changing world of value-based. It's going to change how we practice. It's going to change how healthcare is delivered. And it's all happened in the last 5 to 10 years that this has happened. And nobody understands it.
That's
So,
certainly true, Dr. Carney. When you say no one quite understands Medicare Advantage and different types of plans, our patients certainly don't understand it. And then, coverage in terms of their hospital coverage, Medicare Part A, Medicare Part B, Medicare Part C, which is Medicare Advantage plans, and then Part D, which is their drug coverage.
Drugs.
It's so complicated that it is difficult for us, even as physicians and healthcare professionals, to even understand this, much less our patients. So, it's a complicated system.
and guess what? Geriatricians and palliative docs, we're considered specialists. So if you have a Medicare Advantage plan, I can't see that patient unless they pay me a copay because I'm considered a specialist, which is crazy.
Yeah, absolutely. It's so complex.
So
And, in terms of their coverage, even, as the earlier speaker was mentioning, for SNF coverage, their benefit, having to be hospitalized, you have to have a 3 midnight stay before you even are able to get SNF benefit as a Medicare fee for service. There's so many stipulations in them being able to get the care that they need.
yeah, that is one rule that I think should be gotten rid of, 3 midnight stay, because you have to be weaker and more, exposed to more harm before you can get out of the hospital.
And now they even have, like, if you're an accountable care organization, sometimes you can do the waiver, but not
Right.
everybody can be on it. And the Medicare Advantage, I don't think can be on that. So it's like, again, very confusing for our patients. So,
Yes, it's very confusing. Well, thank you.
Dr. Carney, thank you so much. This was very, very
yeah, thank you.
interesting.
Thank you, Dana, for inviting me here. Appreciate it.